All right, this is a review of the new changes to the home health conditions of participation that went into effect on January 13th of this year, 2018. So we're going to go through the main changes and how Phoenix has adjusted our policies and processes to meet with these new COP requirements. All right, so some of the new standards that we see in the new COPs include an updated transfer and discharge policy with specific requirements on when CMS says that an agency is allowed to discharge a patient. New standards regarding the requirements for complaint investigation, the requirement for a CoP program with an integrated infection control and prevention program. We have new requirements regarding our emergency preparedness. Written information now has to be provided to patients, very specific written information that we'll discuss a little bit later. Clinical record content includes some updates as far as what's required for summaries, discharge and transfer summaries, as well as when those have to be sent to physicians and or facilities. As far as clinical record authentication, nurses are now required, or therapists or anybody taking a home health order, to time the time that the verbal order was received from the physician. As far as clinical record retrieval, agencies are now required to provide copies of clinical records within an established time frame, and those records have to be provided to patients free of charge. Some of the standards that were removed from the new COPs include the requirement for a professional advisory committee, the PAC committee. Now, this is in effect with the new COPs, but as you'll see, the Colorado state laws still require a PAC committee. So until Colorado revises their state laws to align with the new federal COPs, Colorado still requires PAC committees. 60-day summaries were removed, except for in the states of Kansas and Colorado, again, where those are still required in state statutes. And then the requirement for quarterly record reviews was removed with the addition of the new CoP program. They say that the record reviews are no longer a requirement. But again, that is an exception for the state of Colorado, who still requires those quarterly record reviews. So they gave us some information on the new definition of a branch office. So they removed the possibility or the definition for a subunit, and so now agencies have to either be identified as a parent location or a branch office. So with the branch office definition, it no longer requires that the branch office be, quote, sufficiently close to the parent agency. So it removed the requirement as far as the geographic proximity to each other. It also allows that any existing subunits, which already operate under their own provider number, can be considered a distinct agency or a parent branch. Those existing subunits would still be required to independently meet all of the COPs by themselves, including having an independent governing body and an administrator. It also allows agencies that are defined currently as a subunit to become a branch of an existing parent agency. So any agency that's currently listed as a subunit either has to conform to a parent location, or they can submit an application to become a branch. So adding the requirement that the parent agency offers more than just sharing of services, they specify that the parent agency must provide supervision and administrative control of all branches on a daily basis to the extent that the branch depends on that agency for supervision and administrative functions in order to meet the COPs. So we have to be able to show that that parent location provides that type of supervision and control over the branches in order to meet the definition of a branch office. The parent agency would also have to be available to meet the needs of any situation and respond to any issues that would arise with respect to that branch office. So the parent office administration or leadership has to be readily available by telephone or email, fax, some sort of telephonic communication if that branch office were to need anything. The other important thing to remember is when you come into a branch office definition, that means that any violation in any office that is under that parent would apply to the entire agency. So what that means is um, if a complaint survey came into a branch office, that does give the right of that surveyor to then go and survey the parent location as well. So any violation in one branch office would apply to the entire parent agency locations. Lots and lots of changes to patient rights. This was probably one of the biggest reforms of the new COPs. So, with regards to notice of rights, the new COPs require verbal and written information that's provided to both the patient and the patient representative within 4 business days. So, what that means is if your patient identifies a patient representative, we must send that patient representative a notice of the patient's rights and responsibilities within 4 business days after the patient is admitted. Now, the patient can elect not to have a copy sent to their representatives. So, Phoenix has incorporated this in a couple of different ways. There is a new patient handbook that has been created with the new patient rights. So, that is what will be utilized for the written notification of the patient rights. In addition, on the consent and financial agreement, there is now a place where patients can put their initials signifying that they elect not to have that copy of those rights sent to their representative. So it's really important that your staff are aware that that little initial box is on the consents now, and if a patient does not initial there and they have assigned a patient representative, the agency is responsible for getting a copy of those rights sent to that patient representative within 4 business days. Now, in addition to the written requirements, there must be documentation in that admission summary, somewhere in that admission, that documents that a verbal discussion took place regarding the patient rights. Again, Phoenix has met this requirement. We currently use templates, an admission documentation template within the Access system that provides guidance to the clinicians on what is required to be reviewed during an admission. And within that template, there is a section that states that the patient was provided verbal instruction and discussion on patient rights. So very important that if you're not using those templates, that information is still documented somewhere within your admission documentation that a verbal discussion took place. Excuse me. One of the other big things that we're seeing with regards to patient rights is that information must be provided to patients in their preferred language. So Phoenix has obtained written Spanish translation for a couple of documents. Our patient rights and responsibilities are available in Spanish. Our consent for treatment and financial agreement are available in Spanish. And in addition, all of the CMS forms like your HHCCN and your Notice of Medicare Non-Coverage, your OASIS and HIPAA privacy rights, all of those are available in Spanish translation as well. If there is something that is not available in those written documents, or if it's a language other than Spanish, Phoenix has contracted with Language Line Solutions as an option of providing translation services in the home via telephone. So make sure your staff are aware of how to contact Language Line Solutions if it is needed. In your notice of rights, you must inform the patient with contact information for your administrator. So Phoenix has also put that in their patient handbook. And finally, with those notice of rights, the agency must have signature confirming the patient received all of this information. So on our financial agreement and your consent for treatment, there is a bulleted list of everything we are required to provide to that patient in writing. And when that patient signs their consent, they are acknowledging receipt of all of these items. So that is a dual copy form. So a copy remains with the patient and a copy returns to the office and gets uploaded into the chart so that we can show confirmation receipt of all of these items. As far as rights that the patient has, there were a couple of changes. Injuries of unknown source is something that CMS has identified and must be documented and followed up on by the agency. So the definition of an injury of unknown source is an injury that was not witnessed by any person, and the source of the injury could not be explained by the patient. So the attempt from CMS here is to better assess and address and follow up on patients that may be the subject of some form of abuse. So I know our patients fall and bump into things and they bruise easily and they have skin tears that come upon easily, but we are now required that if we assess a patient and see an injury and the patient is, unaware of how it happened or what they did, we have to document that within our nursing note and then, follow up on that at a later time. If you have a patient that seems to have a lot of injuries of unknown source, then we need to be investigating that a little bit further and ensuring that there's no type of abuse occurring. Patients have the right to participate in the care planning process with the agency. It is very important to CMS and the way things are going that the patient is involved in every aspect of their care. So our admit documentation, again, must include that the patient participated in formulating their care plan, which includes identifying a patient goal for their home health stay. Our admit documentation template, again, provides those keywords to ensure that the admitting clinician questions the patient as far as what their patient goals are and includes the patient in the participation in developing their plan of care. Patients have the right to be aware of charges for and frequency of services to be provided and any changes to those charges or frequency of services. So within our financial agreement, you have to identify on that financial agreement which services you're going to be providing to that patient. Skilled nurse, PTOT, MSW, you have to include what the individual charges for those services are. So what's the charge per visit within your agency for a skilled nurse visit? And then you also have to include what the patient's insurance is going to cover. So you will see in our patient financial agreement that you have to circle the bullet. If it's Medicare, you have to circle that it is Medicare. And I'm going to quickly pull up our consent for treatment that is new and revised. So this is what our new consent for treatment and financial agreement looks like. So you see here under charge for services, you have to fill in your estimated frequency and the charge per visit for each service you're going to offer that patient. And then down here on liability for payment, you need to circle the bullet if it's Medicare, if it's Medicaid, or if it's work comp or a different insurance company. All of this information has to be filled out. So we have to know what the Medicaid spend down is. You have to know what the insurance is going to cover, what percentage of the charges, what the patient is responsible for, if they have a deductible that has not been met. All of that information should be collected by intake when they get the insurance authorization. So you should have this information available when you go out to admit this patient. If you do not, then you need to get it before you go out because you're required to tell these patients what their responsibility or their liability for payment is. So make sure you're circling, if it's Medicare, that you're circling that. If it's Medicaid, that you're identifying that within this financial agreement so that it's very clear that the patient has been made aware of these charges. And we talked a minute ago about the request that a copy not be sent to the patient representative. So you can see here, here's where that patient can initial to have to not have to send that information to the representative. Okay, so we are also required to advise patients on community resources that are available to them upon discharge. So within that new patient handbook, we have created a place for each agency to include contact information for the different community resources that CMS says that we're required to provide. So look for that information in your patient handbook and ensure that the patients are aware of that upon discharge, that those community resources are available. Finally, patients have the right to a copy of a clinical record free of charge. That clinical record has to be provided to the patient within 4 business days or at the next scheduled visit, whichever comes first. So if your patient is still on service, the expectation would be they would get that a copy of that record at the next scheduled visit, or if the next scheduled visit is more than 4 days, they would get that record within 4 business days. Now, these records can be hand delivered, obviously by the clinician visiting them at the next scheduled visit, or they can be mailed. We cannot charge for postage anymore, or these records can be sent electronically via email. Now, CMS does acknowledge that most patients do not have secure emails, so they are acknowledging that it's okay for the agency to send them these records by non-secure email. There is also a request for clinical records. Let's see here. I know I've got it in here somewhere. Now, this is a form that we request that the patients fill out in order to get a copy of their records, but we cannot require that this form be completed prior to delivering their records. So again, it's in our policy that we would like them to fill this out, but we cannot require it. So here is an example of the request for medical records form. So the patient would fill this out, they would select a delivery method, and then they would sign it. This would then be uploaded into their chart as reference to the patient's request for their records. Okay, so transfer and discharge. CMS has provided very specific reasons that agencies can discharge a patient. So it's kind of confusing that they refer to this as a transfer and discharge policy. It does not include transferring to an inpatient facility. So this would be if you're transferring and discharging at the same time. So we have revised our policy on discharge to include all of the requirements that CMS specifies. So make sure that you and your staff review that transfer and discharge policy. We're required to provide written notice to patients and their patient representative within 4 business days of that transfer and discharge policy. Now, information has been added to the patient handbook with regards to that policy. So again, when the patient, initials on that box that they do not want all of this information sent to their representative, we would not be required to send this as well. But if the patient does not initial there and they do have a patient representative, we have to send a copy of this discharge information to that patient representative as well. All right, with regards to investigation of complaints, we've revised our grievance policy at Phoenix, and we have clarified, the difference between what we consider a complaint and what is considered a grievance. The way I like to think about it is, patients have simple complaints. They didn't like the smell of somebody's perfume. They didn't like the color of a shirt. Somebody came in and their hair was all messy. Those are complaints that should be able to be resolved at the time of complaint. So those can be resolved by the clinician that is in the home. If a patient calls in and they have a simple complaint as far as that, those can be resolved. Anything that needs to be investigated is considered a grievance, and the administrator is responsible for receiving all grievances and keeping a log of all the investigation findings. So a grievance would be, a complaint as far as, something regarding a patient right. If somebody was not treating a patient with respect, if there was some sort of property damage by a clinician in a patient's home, or any complaint that the patient does not feel like has been resolved by the clinician or the office staff member addressing it. So make sure that anything according to our new policy that is classified as a grievance gets put to the administrator, as they are the ones responsible for that. In addition, CMS is pretty specific that immediate action should be taken if required to remove staff from a patient's case. So if there is any concern regarding, a certain staff member that the patient or the caregiver called and filed a grievance about, even if that claim is not substantiated, we still need to go ahead and remove that staff member from the patient's care team. So ensure that that is getting done and that the patient or the caregiver, whoever files the grievance, is aware that that has been accomplished. Finally, we are required to provide the patient with grievance information as far as our policies. So again, in the patient handbook, that information has been added to that. And then finally, again, with accessibility, patients have the right to access language line solutions at no charge to them. And in addition, we are required as an agency to provide staff with education as far as language barrier training. So there is a handout that all staff are required to get. It is titled Language Barrier Training, and it includes some information on how to identify language barriers, how to address those situations, and then it also at the bottom includes how to contact language line solutions. So ensure that your staff have received that handout and that training so that they are aware of how to utilize the language line solutions option. All right, when looking at the comprehensive assessment, CMS has added some requirements for assessment of the psychosocial and the cognitive status of the patients. So our current EMR access has added enhanced psychosocial assessments for the home environment, including barriers to health status, community resource needs, so on and so forth. That has been included within the OASIS assessments, so that that requirement is met in that way. There's an added requirement for documenting the caregiver's willingness and ability to provide care, as well as their availability and schedule. So again, using our ADMIT documentation template, we have added cues to that clinician where we require that they include who the caregiver is, how often they are available, what they are willing to help with. We cannot assume that all caregivers are willing to help with all aspects of patient care. We see a lot of, sons and mothers where the son does not feel comfortable providing bathing assistance. So it is important that those clinicians document exactly what that caregiver is willing and able to help with and what their availability and schedule is. So are they available every day? Are they with the patient only once or twice a week? That sort of information has to be included in your admission assessment. CMS has approved allowing physician-ordered resumption of care date. So in the past, we have been allowed to use a physician-ordered start of care date, but we have never been allowed to use a resumption of care date after the 48 hours. Now, CMS is very specific that utilizing a physician order for delaying that 48-hour rock cannot be for agency convenience or to correct timeliness of care concerns. So there has to be a valid reason documented why we are not performing that rock within the 48 hours. And this has to be related to, the patient. So if it's a patient request, if it is, sometimes I see things like a patient comes out of the hospital with a wound vac. That's the only thing that the agency is providing to the patient, and it does not have to be changed again for 4 more days. So those types of situations, we would be able to validate a good reason why we are not rocking within 48 hours. But you have to make sure that that physician order that you write has specifics as far as those details. All right, content of the comprehensive assessment. Some of this hasn't changed. They just kind of added in some of those new things. So We always have to assess the patient's current health. We've added the psychosocial assessment, functional and cognitive status. This was the new one where we have to assess and document the patient's strengths, goals, and care preferences. So this includes information that may be used to demonstrate the patient's progress towards goals and goals identified by the patient. So again, using that ADMIT documentation template prompts that assessing clinician to document a patient goal. We have to continue to assess and document the patient's continuing need for home care. So where this is important is we've always seen on our visit notes the section for plan for next visit. A lot of times this section is skipped, but this is going to have to be a requirement. We have to continually assess and document that there is still a skilled need for that patient to continue to receive home health care. So that plan for next visit section is where you would identify that there still is a skilled need and what that need is for the next visit. You have to assess the patient's medical, nursing, rehabilitative, social, and discharge planning needs. So there's a big focus on discharge planning with the new COPs, as you can see with the new discharge policy, the requirement to add community resources available. So discharge planning, we have to show that that discharge planning is being initiated at admission and is addressed at every visit. So what are we doing to ensure that that patient has all of the resources that they need at discharge? How is the patient progressing towards their goals? What additional needs will they require upon discharge? As always, during the comprehensive assessment, a review of all medications that the patient is currently taking have to be done. We have to identify any potential adverse effects and drug reactions, so ensuring that we are using the drug reconciliation or the check for interactions tab within our EMR. And this has to include ineffective drug therapy, significant side effects, drug interactions, duplicate therapy, and noncompliance. So make sure you're running that drug interaction report, that you're addressing it, that you're educating the patient on any major, moderate, and minor interactions, and ensure that those major interactions are being called to the physician within 1 day. So we have to make that call and we have to hear back from them as far as what they want to do regarding that major interaction within 1 day. All moderate interactions have to at least be faxed to the physician, and then the patient requires education on all drug interactions. So make sure that that is being completed. We already talked about documenting the patient's primary caregiver and the willingness and availability of that caregiver. Have to identify at the comprehensive assessment if the patient has an identified patient representative. And then finally, that all the OASIS information is included. So that is the content requirements of the comprehensive assessment. Now, when we look at the plan of care, there are new items that have to be now documented on that plan of care that the physician signs. So the risk for emergent care services, what is that patient's risk? Access has put in a couple of new assessments for assessing for hospitalization risk. Those are required to be completed. And then if the patient is at high risk, we would expect to see interventions for high risk hospitalization within the plan of care. Advanced directive information has to be documented on the plan of care, so that's going to include any DNRs, any power of attorneys. Psychosocial assessment, again, our EMR Access has put that assessment within the OASIS, and information will now flow to the plan of care based off of that assessment. Patient and caregiver education and training to facilitate timely discharge. So what this means is we're identifying at admission what that patient may require to discharge timely. So what kind of education must they receive, or where must they show competence before they can be discharged? We really have to look at that too when we look at the rehab potential. In the past, we have documented rehab potential as poor, fair, good. CMS is saying no, they need some more specifics. Their expectation for seeing rehab potential is it is expected that the patient will return to a modified independent status. or it is expected that the patient will continue to require medication setups. Whatever we identify as what is the true rehab potential for that patient. And then, as always, our patient-specific interventions, education, including measurable outcomes and goals. And we also have to make sure that that patient goal is part of the plan of care. Really important that we document that verbal orders were received for this plan of care until we get that signed plan of care back from the physician. So we have to have some sort of order to continue to provide care to that patient until we get that written plan of care signed. So what that means is in your documentation on admission, there has to be documentation that shows that a verbal order was received from that doctor to implement this proposed plan of care, any specific interventions or focus for that plan of care. So again, in that admit documentation template, there is an MD communication section that goes through and says that the physician approved the plan of care, focusing on this, that they ordered or approved physical therapy or occupational therapy, so on and so forth. So again, very important that we're documenting that we did receive verbal confirmation to implement this plan of care. And then finally, any revision to the plan of care due to a change in the patient's health status must be communicated to the patient representative, any caregivers, and all physicians issuing orders on the plan of care. So where this comes into play and how this is important, we'll discuss a little bit when we talk about the SCIC, or the significant change in condition, but it's also important when you're thinking about the physicians that you're putting on your plan of care as far as may take orders from. So we're going to get into that here in a couple more slides, but just be aware that we have to show notification to that patient representative, caregiver, and all physicians when there's any revision to that plan of care. So here's the key as a reminder for verbal orders. The clinician taking that verbal order has to time a timestamp of when they received that. So you can't just say verbal order received by Jane at Dr. Cavero's office. It has to say a time. So verbal order received from Jane Smith RN / Dr. Cavero at 10:15 a.m. on 1/1 of 2018. Now, the orders that actually get printed and sent to the physician should have that, but we need to make sure that we are actually, typing that into the physician order form that, this verbal order was received by this person at this time. A lot of times, these orders are received from nurse practitioners or the nurse working with the physician. So it's really important for that physician to be able to go back and say, okay, where did this come from? Oh, it states right here that it was a verbal order from Trish on this date at this time. So make sure that that information is included when you're writing up those physician orders, that, just like you would, if you're working in a hospital or anywhere else that you weren't using this EMR, verbal order received by who, at what physician's office, on what date and what time. All right, so the SCIC, the significant change in condition, is something that, we used to use quite often. It used to be that if you had a significant change in condition, you would complete a new OASIS, and your reimbursement would change based off of that deterioration in the patient's condition. Well, CMS quit reimbursing for SCICs, and so they kind of went by the wayside and everybody kind of forgot about them and quit doing them. Well, they're back. CMS has quite a few spots within the new COPs where it talks about significant change in condition and the requirements that the agency must take when that condition changes. So they were specific that an OASIS follow-up is required for a SCIC. And what they consider a significant change in condition is addition of services, increased frequency of services, outcomes not being achieved, plan of care alterations, change in health status, or a change in discharge plans. So what this means is CMS is going to expect to see a follow-up OASIS with, alterations in the plan of care being performed if you add services. So if you're halfway through your episode and you add therapy services, they want to see a follow-up OASIS as to why, what changed in the patient's condition. They want to see that that plan of care has been updated to include those change in services and frequencies. Along with that, we are required still to complete the HHCCN, or the change of care notice, anytime we are adding or removing services or supplies that were offered to the patient at start of care. In addition, we are required to provide patients a financial update of those new services. So, if you started your episode or your start of care with just nursing, halfway through the patient falls, needs therapy, on the original consent for treatment, the only thing that would have been checked is your nursing, say, 1 time a week. Well, now we're going to add therapy and we're going to increase the frequency of our nursing services. That's a significant change in the patient condition that is requiring these changes to the plan of care. So we're required to do an OASIS follow-up. We're required to update the plan of care, and that update has to be sent to the physician that's ordering the plan of care and any physicians issuing orders. So that means if you have an order on your plan of care that says may take orders from, and you list 5 different docs, we're required to send that updated plan of care to all 5 docs. In addition, we have to fill out the HHCCN. We have to fill out the financial addendum where we're adding therapy and we're notifying the patient what the cost of therapy is, what their insurance will cover, and we also are required to send all that information to the patient representative. Finally, they say that there must be documentation of a verbal discussion and that those documents were signed. So again, if you are adding those services, we would expect to see information added to the plan of care, that information is communicated to the patient and the patient representative, all physicians, and that we have the signed HHCCN and financial addendum in the chart. With regards to coordination of care, when we talk about that may take orders from, this is where we have to get a little bit more picky about, not putting every single physician that the patient might see. The only physicians that we should be seeing on that may take orders from is physicians that are impacting the home health plan of care. So, for instance, if we're treating a cardiac disease, we should be contacting that cardiologist and including them in anything that we are educating or providing intervention on. If we're treating a wound, we would expect a wound care specialist to be involved in that plan of care. Now, the certifying physician must still approve integrating orders from all these physicians, and that's where we see the may take orders from on our plan of care. But, if you are not addressing the patient's AFib during your, in your home health plan of care, you're addressing, say, a fractured hip, then we don't need orders from the cardiologist to address that fractured hip. This is where we have to be very specific in our plan of care of what we're doing. We are not there to treat every 15 disease processes the patient may have. We have a focus of care, and we have to ensure that our plan of care reflects that. Written information that we are required now to provide to the patient. We're required to provide the patient with visit schedules and estimated frequencies, a medication schedule, any treatments the agency is going to be providing, any pertinent information related to the care, and the name and contact information for the clinical manager for that patient. Now, all of this information has been combined into the new patient handbook and can be found under what we have labeled the home health plan of care. So I am going to pull that up for you guys. Let me get it here. I think it's in this one. All right, so here it is. Here is the new home health plan of care. Now, this allows you to write in who the patient's primary physician is, what their phone number, who's the clinical manager, and then the names of any people that they may have coming into their home. So their RN is going to be this person. Their physical therapist is going to be Christy. Their PTA is going to be Leanne. Any treatments ordered. So if the home health agency is going to be providing wound care, catheter changes, PICC line dressing changes. Those are treatments. So we just need to fill that in here, wound care or PICC line dressing change. And the instructions section is where we need to provide any pertinent information to that patient. So for instance, if the patient has a wound and the wound care orders are for twice daily dressing changes, but the nurse is only seeing that patient, once a week to assess for changes or infection, then we need to include detailed instructions on how that patient is supposed to be performing their wound care. Now, I am currently working on trying to get some templates created with some basics as far as ensuring, that we are spelling out to patients how to perform wound care. Because remember, we have to write it in a language that they understand. We can't use medical jargon. So be looking for those templates to come out here in the next month or so. But it'll be something simple like, cleanse your left knee wound with, sterile water. Pat it dry with sterile gauze. Apply triple antibiotic ointment to it and cover it with, a dry, non-adherent bandage. So it's going to include, those blanks where you can fill in the specifics, but it's going to ensure that that information is presented in a manner that the patients understand. Finally, you see here the calendar of visits. So the expectation here is, that PT goes out and does an evaluation week 1 on Tuesday, and they say, your PTA is going to be back out on Friday. And so she goes ahead and writes PTA on that Friday. The PTA comes out and they establish with the patient, they're going to see the patient every Tuesday and Friday. So they go ahead and fill in that is the plan, is for the PTA to see them every Tuesday and Friday. So they'll fill PTA in on this calendar. Now, that is not to say that, this is set in stone, that things won't change, but at least the patient has an estimate or something, to work off of, because like I said, we are required now to work with the patients and their preferences. If we know we can't see them on Mondays, then we need to write that on the calendar so that nobody plans a visit. But the expectation is that every person seeing this patient will add their discipline abbreviations to this calendar. Finally, there's a blank medication list here. Now, we're required to provide the patient with a schedule of medications. We're required to provide all of this information within the 5-day window. So, the situation arises now, okay, you're out there and you're doing your medication reconciliation, but say you don't finish that med reconciliation or adding the specifics to your med list until you get home that night. That means we don't have anything to leave in the patient's home, and you may not be back there for another 5 days. So there's a couple workarounds to this. Number one, you can fill this blank medication list and leave with the patient. Or if you have like their medication discharge list from the facility, you can use that and kind of go through and check mark what they're still taking, add medications to that list that you found in the home, cross medications out, but at least we're leaving that patient something at the time of admission that has their medication schedule. And then the expectation is that before each visit, as far as nursing visits especially, but therapy has to be aware of this as well, is that that clinician will review and see if there's been any medication changes, and they will print a medication list to take to that patient before they go out for that visit. So that the patient always has an updated med list. Now, if you're in the home and you find a new medication, you need to go ahead and write it into that medication list at the time of your visit. And then the expectation is that the next person that goes out will print that updated list and take a printed list to that patient. Surveyors have been instructed to ask the patient for their written medication schedule if they were to go and do a survey visit with that patient. So it's imperative that we always have an accurate medication schedule for that patient in the home while they're on service with us, and we're required to provide that to them at discharge as well. So however your branches want to, accommodate this, it's just important that you can always say that patient has an accurate med list in their home. Here is on that, this is information that's in your patient handbook that we talked about. So here's the organizations or community resource information. Here's the transfer and discharge policy that's included in our patient handbook. So like I said, all the information should be there within that handbook. Just make sure everybody's using the updated forms. All right. Excuse me, I had to take a drink. So CoP is a new COP that CMS put out. We kind of went through this. If you've watched the emergency disaster preparedness webinar, this is included in there. So I'm not going to spend a whole lot of time, but basically, what you need to know is the CoP program that we have developed focuses on patient safety and quality of care. It's based off of the agency's adverse or negative outcomes. And part of my role with CoP is to measure, analyze, and track those quality indicators or your patient adverse events. We must have a CoP program that's capable of showing measurable improvement. So we'll be monitoring improvement in all of these areas on a quarterly basis. And it must include infection control, surveillance, investigation, control, and prevention. So we're going to talk about that here in just a minute. The data we use in our CoP program, the majority of it is OASIS data, but we also use HCAHPS data, patient grievances, things along those lines. The data based off of the requirements must monitor the effectiveness and safety of the services and quality of care we provide. It should identify opportunities for improvement. And the governing body has ultimate responsibility for approving the frequency and the collection of all of that data. So some of the activities we're doing for our CoP program focuses on high risk, high volume, and problem prone areas. So we're looking for anything that is a safety concern. We are immediately putting in plan of action or correction for anything that we find there. We're tracking the incidents and the adverse patient events, analyzing their causes, and implementing any preventative actions. So that's part of my role, is going to be, analyzing and auditing those patient events and seeing, if there's any way that the agency could have done things differently. And then final activity, monitoring and tracking performance for sustained improvement. Again, that's where we look at, your quality indicators at least on a quarterly basis. So performance improvement projects is your big project, has to be conducted at least annually, and it must document the project that you chose, the reason for conducting that project or choosing that project, and it must show documentation of measurable progress. So this is where each of the branches submitted what they wanted to work on for the year. The governing body has approved all of those projects, and then we will look at the progress achieved on a quarterly basis. And then the expectation is that you would have a new project at least once a year. So the role of the governing body in CoP, just basic oversight to ensure the program is implemented and maintained, that we're ensuring that it's focusing on patient safety and quality of care, that all of the action items are evaluated for effectiveness. So, if during these audits that I'm doing, we don't feel like we're getting much data out of it, we'll look for, another way to evaluate those. To establish clear expectations that this is regarding patient safety, and to address any findings of fraud or waste. So the governing body's been educated on their role in the CoP, and going forward, just knowing that, the governing body is ultimately responsible for all branches, ensuring that all branches are focusing on the CoP. So part of our infection control program, first with surveillance, there are patient infection logs built within Access. So the expectation is that any patient that is started on antibiotics, is diagnosed with an infection, or if they come on service at start of care on antibiotics or with an infection, that we that we are completing an infection log in Access for that patient. Your administrator also keeps an employee infection log. So it's expected of the employees that if you get started on antibiotics, if you're diagnosed with infection, that you report that to your administrator so they can log it. Now, how this comes into play is part of my role is then to look at all patient infection and employee infection logs, trend those, look for causative factors, and look to see if there's any cross-contamination between an employee infection and a patient infection. Your administrator also keeps an occupational exposure log. This is going to include any needle sticks or splash accidents with body fluid. So, obviously make sure your administrator is aware of any of those incidents. I will also be looking at OASIS reported infections. So that's going to be like your patients that go to the emergency room or the hospital with wound infections or UTIs. And then finally, we have to surveillance vaccinations. So we were required in our OASIS, we should be seeing that the vaccination record for patients includes at the bare minimum flu, pneumonia, and shingles. So those are things that we have to document and ensure that we have, appropriate data on for each patient. In addition, that we are required to track employee vaccines. So currently, Phoenix does not require any vaccines. The only thing we require currently is the tuberculosis screening, but obviously flu vaccines are very much recommended by the CDC for all healthcare staff. So the agency and your administrator are responsible for documenting if you've had a flu vaccine, and so on and so forth as far as reporting that to the CDC. Part of our infection control is reporting and identifying any symptoms. So part of the program we implemented is flu-like symptom reporting. So during flu season, a couple things that we're looking at here. Number one, the expectation is that staff are calling patients before their visits, and that during flu season that you kind of probe that patient before you make that visit to find out if that patient or a family member in the house has the flu. If they do, it's recommended, if possible, that we change that visit date to another date. If it's not possible, then you need to go in making sure you're wearing the appropriate PPE. And then finally, if you are assessing a patient and they have flu-like symptoms, now I'm not meaning they just have a fever or they just have a runny nose, but they have a couple of symptoms that make it seem like they are, very possibly have the flu, the expectation is you're reporting those to the physician and that you're getting them and helping them to get treatment for those symptoms. With analysis and investigation, again, I am tracking and trending patterns of infection and looking for possible causative factors or sources. And then finally, with a control of spread, that includes using your PPE, that includes, hand hygiene, infection control, standard precautions, things along those lines. So when we look at prevention, Phoenix has an updated standard precautions policy that outlines hand hygiene, environmental cleaning and disinfection, injection and medication safety, appropriate use of PPE, minimizing exposure, and reprocessing of reusable medical equipment. So you need to make sure that you have received the handout as part of the education on that updated policy. That education includes the standard precautions and transmission-based precautions education, as well as the standard precautions policy. We've also implemented some additional education in the patient handbook that provides education on hand hygiene, cough etiquette, and immunizations. So you'll see that within the new patient handbook as well. Lots of new changes regarding home health aides. This is a really big stickler in the state of Missouri, so Missouri offices make sure and pay close attention to the regulation changes with home health aides. There have been some revisions made to the qualifications as far as the competency program that aides go through. So it can be a training or an evaluation program provided by the agency. It can be an evaluation program that meets the requirements of the state, which you'll have to, dig in to find that, or it can be a nurse aid training and competency evaluation program that's been approved by the state as meeting all of the guidelines. So, most states have certain guidelines as far as education, so each state is a little bit different on what their requirements are. But, a lot of things take into account, if you have a CNA certificate, that is considered completing an approved state program. Some of the colleges here in Missouri offer different CNA programs or home health aid programs. So you just really need to, when it comes to hiring home health aides, make sure you're looking at your state qualification requirements. Now, supervision of home health aides, they did make adjustments in the regulations to allow persons other than the registered nurse to supervise those aides. So PTs, OTs, and speech therapists can do the aide supervisory visits. They changed the requirement for, it used to say that the aide sup was required every 2 weeks. It now says 14 days, and it does specify that those have to be on-site supervisory visits. Now, that does not mean the aide has to be present during that, but it does mean that the nurse or the therapist has to be in the patient's home. Those sup visits cannot be conducted over the phone. And then finally, it specifies that an annual on-site supervisory visit is required with home health aides during, an actual patient visit. So an on-site visit at least annually. There are some specifics that CMS has outlined as far as what should be assessed during a supervisory visit. Now, I have not seen the sup visits being changed currently in Access, so this is something that we may have to create a template to ensure that all of these things are being assessed during aide sup visits. So the aide has to be assessed for following the plan of care, maintaining open communication with the patient, caregivers, and family, demonstrating competency with the assigned tasks, complying with infection control policies, reporting changes in patient condition, and honoring patient rights. So when you're documenting your aide sup visits, we need to make sure that we're hitting all of these assessment criteria. And then finally, some new training. So they added required training for home health aides for communication skills and recognizing and reporting changes in skin condition. Missouri has issued out a revised competency evaluation for all new staff, which includes these new requirements. And they've also created an in-service for existing staff just on these 2 new ones. So make sure you're looking at those. Make sure your aides that are currently on staff have an in-service of the new requirements for communication skills and reporting changes in skin condition. And then make sure any new staff have completed all of the new requirements. We did revise the job description and training policy for home health aides, so make sure to look for that in your updated policy book. So looking at the competency requirements for home health aides, not much of this has changed, but one thing that they did provide a little more guidance on is that certain assessments or competencies have to be evaluated by observing that aide's performance with a patient. So you must observe the aide for these skill checkoffs. They cannot be simulated, and you cannot use a mannequin. So look over this list here as far as, communication, personal hygiene and grooming tasks. Those concepts or those evaluations have to be made with a patient. The remaining areas on the competency evaluation can be completed through written, oral, or observation. So make sure you're reviewing that training policy that's been updated to ensure that your aides are being checked off for their competency evaluations in a proper manner. Laboratory services, CMS is pushing for the fact that patients own and utilize their own testing equipment. So this includes glucometers, pulse ox, INR machines, so on and so forth. So what this means is, and they've kind of made some specifications here where agencies are allowed to use the agency equipment, but only for a short duration of time. So what that means is if you have that, knee replacement that's only doing INRs for, 2 weeks, then there's no reason that that patient needs to obtain their own equipment. The agency can use ours. But if you have the atrial fib patient that's chronic Coumadin and has to check INRs at least once a month, they are patients that CMS is saying need to actually have their own equipment. So the agency's responsibility in that is to help those patients to secure that equipment. So getting in touch with their physician and starting the process to help them get their own equipment. Emergency preparedness, we go over this really well in the other webinar, but basically what you need to know is updated annually and approved by the governing body. The hazard vulnerability assessment is required to be completed by each agency annually. We have to address any emergency events that are identified in that assessment and how the agency would respond. We have to ensure or provide information on how we would continue to operate, how authority would be delegated. The process for cooperation and collaboration with all other emergency preparedness officials. We have to show that the individual patients have plans for emergencies. So, we've met that in our comprehensive assessment by identifying their triage level and also by identifying any equipment or needs that the patient would have for evacuation. So, does that patient have somebody to assist them to evacuate? Would we have to send emergency responders if that patient had to evacuate? In addition, what do they require? Are they oxygen dependent? Would they require a hospital bed? So on and so forth. We have to identify procedures to ensure follow-up with staff and patients. We have to ensure HIPAA compliance with our documentation. We have to show staffing strategies and where we would look for additional staffing sources, what the communication plan is to contact emergency preparedness officials, staff, and our patients. And then finally, a training and testing program, which includes a full-scale exercise and a tabletop discussion annually. So make sure that everybody has listened to the Emergency Disaster Preparedness in Service webinar. It is still on the InDrive, but that is a requirement to meeting the COP. As far as clinical records, summaries, so they removed the requirement for the 60-day summaries except for Kansas and Colorado that still have those regulations, but they did clarify and specify that discharge summaries have to be sent to the physician within 5 business days of that patient discharge. So the expectation of the agency staff then is that your discharge summaries are present and completed at the time of discharge so that we can ensure those get sent within 5 business days. Now, Access does not have any way of automatically sending those, so that is the responsibility of somebody in your office as far as pulling those discharge summaries and manually faxing those to the physicians. Same applies to transfer summaries, but their stipulation in transfer summaries is that they have to be sent within 2 business days and they have to be sent to the physician and the receiving facility. So what this means is the minute you find out about a transfer, we need to be, finding out what the reason for that transfer was. Why did the patient go in? We need to complete a transfer summary and we need to send that summary to the facility the patient is in, as well as to the physician within 2 business days. Now, there are times that we don't find out about a transfer until a patient has come home. So obviously there is no reason to send a transfer or a transfer summary in those scenarios. But if your patient is still in that facility, even if they transferred out, 4 days ago, if they're still at that facility, we are required to send a transfer summary over to them immediately. Need to ensure that our summaries include all of the following information. This was specified within the COPs, so make sure that all of this information is included within your transfer and discharge summary. And finally, make sure that records we can show are being retained for at least 5 years following the patient's discharge. So CMS provided additional requirements and duties for the administrator and the clinical manager. Administrator has not changed a lot, but one of the big things that came out is identifying that the administrator cannot be named the clinical manager as well. The administrator has to be responsible for all the day-to-day operations. They monitor to ensure that the staff are qualified based off of their requirements. And then the clinical manager has the following new responsibilities: making patient and personnel assignments, coordinating patient care, coordinating referrals, assuring that patients' needs are continually assessed, and assuring the development, implementation, and update to the individualized plan of care. So, within Phoenix, we have made the decision that our case managers complete the majority of the duties that are assigned to the clinical manager. So our case managers are having a title change to clinical manager. Now, it's my impression that CMS, what they're really looking for here is that one person that ensures that patient care is being coordinated through the staff, through the physician, all of the disciplines, that the plan of care is being updated with any changes in condition. So our case managers do fit this. I really think, when CMS made this, they were thinking more in terms of like a team leader type style, where you have that one person that's in the office that handles a certain number of patients and, looks at all the OASIS for those patients, handles all the orders, looks at all of the nursing and therapy notes that come through, sends all the summaries. They are the hub for all of the coordination of that patient care. Unfortunately, at Phoenix, we are not set up like that. We do not have that type of support system within our office locations. So the decision, for us has been that the case managers do perform. They are the ones currently that are ultimately responsible for that patient's plan of care. So they are currently the ones that have these duties. Now, we do have revised job descriptions for every job here in home health. So we do need to make sure that every employee is signing a new job description as they have been revised to meet some of these new COPs. So administrators, make sure you're pulling those new job descriptions and getting new job descriptions signed by every person in your agency, including yourselves as the administrator. So this was just something to review. This is, my role has been redeveloped as the Director of CoP and Regulatory Compliance. So this kind of details what I am going to be doing for each of your locations. We've kind of gone through all of this. I just wanted to provide it to you as a breakdown of the audits that I'll be doing and how I will be assisting you guys in your CoP, in your emergency preparedness, so on and so forth. So this is a list of the policy revisions that we have seen within Phoenix that have significant change. So we redid every policy that we have here at Phoenix in December. So we have a brand new policy book that each branch needs to be printing out and reviewing. But these are some of the policies that have significant changes in them that I need you all to make sure that you are reviewing the individual policies and they look okay for you guys. So make sure and review this list of policies specifically when you're printing out your new policy books. And then this is just a list of some of the updates that we have seen within the Access EMR. So we've talked about most of these, but you will be seeing a lot of changes with the way the plan of care is developed in Access. I know we are already seeing, quite a few hiccups and things not flowing. We will continue to be working with Access and working with our QA staff to identify some of these areas, looking at how our templates come into play and whether they're still needed. So, hang in there with all these new Access updates. We all feel like we're starting from scratch here. It's new to everybody. But these are just some things that I know with looking at some of the Access updates, we are seeing or we will see within the very near future. So staff training requirements based off of our new policies and some of the new programs we rolled out. Just want to make sure everybody is up to date on the staffing requirements. I also sent out a new checklist as far as orientation. So this is included on that orientation checklist, as well as the required in-services every year. So all staff are required to complete 12 hours of in-service each year. 7 of those we have as requirements as far as what is required annually, and then 5 additional ones. So make sure you're reviewing that new checklist, as well as the skills checklist for your glucometer and INR machines. New patient information that just got rolled out includes your new patient handbook. That includes the revised patient rights and responsibilities, the new home health plan of care, transfer and discharge policies. Please make sure you guys are providing these updated information tools as the patient rights have in fact changed. So we need to make sure we're providing updated information. Also make sure we're using the new consent and financial agreement and addendum. Make sure we're completing HHCCNs and financial addendums for changes to care being provided. And then, look for all of this additional information in your new patient handbook as far as fall prevention, home safety evaluations, and infection control. All right, that pretty much covers, the COP changes that we've seen come into play, and how Phoenix has made some changes in our processes and our policies to accommodate that. If you have any other questions, please feel free to reach out to me anytime. I'm at extension 1049. I'm here for any questions you guys have, and I appreciate everybody's time, and thank you for participating.